Every single morning, millions of Americans over 60 swallow a pill they believe is protecting them. And in many cases, that same pill is quietly destroying one of the most vital organs in their body. Not fast, not dramatically, slowly, silently, until the damage is done. Most doctors won't tell you this, not because they don't know, because they assume you can't handle the information, but I think you deserve the truth. Stay with me until the end, because the number one thing I'm going to reveal today is something your pharmacist has never mentioned, your doctor has likely never discussed, and yet it could be the single most important thing you do this year to protect your kidneys. One specific combination that reduces kidney stress by over 40% in adults over 60. And almost nobody knows about it. I'm Dr. Eleanor Whitfield, a physician specialized in senior health with over 15 years of dedicated clinical experience. I've worked with thousands of men and women, over 60 navigating the complicated world of blood pressure management. And what I've witnessed in my clinic has changed the way I think about medication entirely. What I'm about to share goes against what most patients are told at their annual checkup. But I've seen it with my own eyes, patient after patient, and I refuse to stay silent any longer. If this information seems valuable to you already, hit that like button right now. It helps this message reach the people who need it most. Now let's talk about what's really happening inside your body. Your kidneys are not passive organs. They are working every single second of every single day. They filter approximately 200 liters of blood every 24 hours. They regulate your blood pressure, your fluid balance, your electrolytes. They produce hormones that keep your bones strong and your red blood cells healthy. They are, in every sense of the word, essential. After 60, your kidneys naturally begin to lose some of their filtering capacity. This is normal. A healthy person in their late 60s typically has kidneys functioning at around 70 to 75% of their peak capacity. That's still enough. That's still manageable. That's still a good life. But here's what terrifies me most. When certain blood pressure medications enter the picture, that natural, manageable decline accelerates dramatically. We're not talking about a slow, gentle slope anymore. We're talking about a cliff. And millions of seniors are walking toward that cliff every single morning with a glass of water and a pill they trust completely. The kidneys receive roughly 20 to 25% of the heart's entire blood output with every single beat. They are exquisitely sensitive to changes in blood pressure, blood flow, and chemical environment. When a medication alters any one of those variables aggressively, the kidneys pay the price. And they don't always send you warning signs. Not at first. The damage accumulates quietly for months, sometimes years before the numbers in your blood work finally tell the story. Here's what's happening inside your body right now if you've been on blood pressure medication for more than 2 years after the age of 60. The small blood vessels inside your kidneys, called the glomeruli, are under constant chemical stress from certain drug classes. Some medications reduce blood flow to these tiny filters. Others cause microscopic inflammation in kidney tissue. Others deplete critical minerals that the kidneys need to function properly, and when those minerals drop, the entire filtration system becomes inefficient, sluggish, and increasingly fragile. The medical community has known about this for decades. Studies going back to the 1990s clearly showed the nephrotoxic potential of several commonly prescribed antihypertensives in elderly patients. And yet, the prescribing habits have changed very little because managing blood pressure is genuinely important. Because the risk of stroke and heart attack is real. Because nobody wants to be the doctor who took away someone's blood pressure pill and watched them have a cerebral event 3 weeks later. I understand that. I respect that caution. But there is a middle ground, and that middle ground is what I'm here to show you today. Before we continue, I want to ask you something. How long have you been taking blood pressure medication? Less than a year, 1 to 5 years, or more than 5 years? Type your answer in the comments below. You might be surprised how many people share your exact situation. Today, I'm going to walk you through 7 blood pressure medications ranked from most concerning to least concerning for kidney health in adults over 60. And for each one, I'm going to tell you exactly what the science says, what the risk looks like, and what you can do about it. This is not a list telling you to stop your medication. This is a list that gives you the knowledge to have a real conversation with your doctor. The kind of conversation most patients never have because they don't know the right questions to ask. Let's begin. Number 7 on our list is hydrochlorothiazide, commonly known as HCTZ. This is one of the most prescribed blood pressure medications in the United States. Millions of seniors take it every single day, and on the surface, it seems harmless. It's been around for decades, it's cheap, it works. But here's what most people aren't told. Hydrochlorothiazide is a diuretic. Its mechanism of action involves forcing your kidneys to excrete more sodium and water, which lowers blood pressure by reducing fluid volume in your bloodstream. That sounds logical. That sounds clean. But forcing the kidneys to work harder, to produce more urine, to constantly flush more fluid means the kidneys are under sustained mechanical stress, particularly in patients who are already in a state of mild dehydration, which is extremely common in adults over 60 because the thirst mechanism weakens significantly with age. A study published in the Journal of the American Medical Association found that seniors taking thiazide diuretics, who were even mildly dehydrated, showed markers of acute kidney stress at rates 34% higher than those who maintained optimal hydration. And here's the problem. Most seniors on HCTZ don't know they need to be drinking significantly more water. Their doctor mentioned it once briefly at the initial prescription appointment, and that information got lost somewhere between the pharmacy and the kitchen counter. Additionally, HCTZ depletes potassium. And potassium is not just a mineral your body needs for muscle function. It is directly involved in maintaining the electrical environment inside kidney cells. When potassium drops chronically, kidney cell efficiency drops with it. Over months and years, this contributes to a gradual decline in GFR, which is your glomerular filtration rate, the primary measurement of how well your kidneys are actually working. Here's the pro tip for number 7. If you're on HCTZ, ask your doctor to check your potassium level at every single blood draw, not just once, every time. And consider discussing potassium-rich dietary additions like cooked sweet potatoes, white beans, and avocado with your care team. These are simple food-based strategies that support kidney function without interfering with your medication. But that's not all. Let's move to number 6. Number 6 is amlodipine, a calcium channel blocker that's also incredibly common. Amlodipine works by relaxing the walls of blood vessels, allowing blood to flow more easily and reducing the workload on the heart. For many seniors, it works extremely well with minimal side effects. And compared to several other medications on this list, its kidney risk profile is genuinely lower. However, there is a significant caveat that most patients over 60 are never warned about. Amlodipine can cause ankle swelling, a condition called peripheral edema, in a significant percentage of elderly patients. Studies suggest that up to 30% of seniors on amlodipine experience notable fluid retention in the lower extremities. And this matters for kidney health because fluid that pools in your ankles and legs is fluid that is not circulating properly. It is fluid that your kidneys are struggling to redistribute. Over time, chronic edema signals to the kidneys that the fluid regulation system is under strain, which initiates a cascade of compensatory hormonal responses that elevate kidney workload. Furthermore, many doctors respond to amlodipine-induced edema by adding a diuretic to the patient's regimen. Suddenly, you're on 2 medications that both affect kidney fluid dynamics simultaneously. A 2019 study published in Frontiers in Aging found that seniors on combined calcium channel blocker and diuretic therapy showed accelerated decline in kidney function markers compared to those on either medication alone. The pro tip for number 6. If you are on amlodipine and you have noticed swelling in your ankles or feet, do not ignore it and assume it's just aging. Report it specifically to your doctor and ask whether a medication adjustment might reduce the edema without requiring an additional diuretic. There are strategies, there are alternatives, but you have to ask. Now let's move to something more serious. Number 5. Number 5 is lisinopril, and this is where the conversation gets more complex. Lisinopril belongs to a class of medications called ACE inhibitors, and it is prescribed to an enormous number of seniors for blood pressure management. In many patients, it is genuinely protective for the kidneys, particularly those with diabetes. That is true, and I want to be honest about that nuance. But here is what the research also tells us. In a subset of seniors, particularly those over 70, those with pre-existing mild kidney impairment, and those who are taking NSAIDs like ibuprofen or naproxen for joint pain, lisinopril can trigger a serious and acute reduction in kidney filtration. The mechanism involves the medication's effect on a specific hormone system called the renin-angiotensin-aldosterone system. ACE inhibitors block part of this system in a way that reduces pressure inside the kidney's filtration units. In most patients, this is beneficial. But in patients with narrowed kidney arteries, a condition called renal artery stenosis that is surprisingly common in older adults and often completely undiagnosed, this same pressure reduction can be catastrophic for kidney function. A study in the New England Journal of Medicine found that among seniors over 70 placed on ACE inhibitor therapy, those with undiagnosed bilateral renal artery stenosis experienced acute kidney injury at rates that were alarming. And the tragedy is that these patients felt fine. They had no warning symptoms. The damage appeared only in their lab work. The pro tip for number 5. If you are on lisinopril or any ACE inhibitor and your last kidney function test was more than 1 year ago, ask your doctor for an updated creatinine and eGFR panel. These are simple blood tests. They are inexpensive. They tell you exactly what your kidneys are doing right now. This one test could change everything. I want to share a story with you here because this is exactly the kind of situation I'm describing. I remember Margaret, a 74-year-old retired school teacher from Atlanta. She had been on lisinopril for 6 years. Her blood pressure was beautifully controlled. Her cardiologist was pleased. She felt, by her own description, perfectly fine. She came to my office not for her blood pressure, but because she had started feeling unusually tired in the afternoons. The kind of tiredness that sleep didn't fix. She assumed it was just getting older. She had been told, after all, that fatigue was simply part of life past 70. I ran a comprehensive panel. Her eGFR, her kidney filtration rate, had dropped from 74 at her last recorded test 3 years prior to 51. She was now in stage 3 chronic kidney disease. She had crossed that threshold without a single warning symptom. When we dug deeper, imaging revealed mild bilateral renal artery narrowing. Her lisinopril, which had been protecting her heart beautifully, had been quietly stressing her kidneys for years. We worked with her cardiologist to transition her to an alternative medication that controlled her blood pressure through a completely different mechanism. Within 4 months, her kidney markers had stabilized. The decline had stopped. She told me, with tears in her eyes, "Dr. Whitfield, I had no idea. I thought I was doing everything right." And she was doing everything right with the information she had. She just didn't have enough information. That changes today. This wasn't a failure of medicine. This was a gap in communication. And it is exactly the kind of gap I'm here to fill. If you're finding this valuable, please take 2 seconds to hit the like button and subscribe to this channel. My entire mission is to give adults over 60 the clear, honest health information they deserve. And if you know someone on blood pressure medication, please share this video. A simple click could start a conversation that genuinely changes someone's life. Moving on. Number 4 on our list is losartan and its related medications known as ARBs, or angiotensin receptor blockers. ARBs, like losartan and valsartan, work through a mechanism similar to ACE inhibitors, but at a slightly different point in the same hormonal pathway. They carry many of the same benefits and many of the same risks for kidney function in older adults. Like ACE inhibitors, they can be genuinely kidney protective in diabetic patients, but they share the same vulnerability in patients with renal artery stenosis, and they present an additional risk that is less commonly discussed. ARBs can raise potassium levels, a condition called hyperkalemia. In young, healthy kidneys, excess potassium is simply filtered out and excreted. But in kidneys that are already showing age-related decline, potassium can build up. And elevated potassium levels are not benign. They affect heart rhythm, they affect muscle function, they create a cycle of stress that ultimately worsens kidney performance. A 2021 study published in the Journal of Clinical Nutrition found that seniors over 65 on ARB therapy who also consumed high potassium diets, including supplements, showed elevated rates of kidney stress markers compared to those who monitored their potassium intake carefully. Here's the pro tip for number 4. If you are on an ARB, be cautious with potassium supplements and be aware that several foods marketed as heart healthy, including certain salt substitutes, are extremely high in potassium. Something as simple as switching to a low-sodium salt alternative could be dangerously raising your potassium if you're on this medication class. Discuss this specifically with your doctor or pharmacist. Now we're entering the top 3, and this is where the risk escalates significantly. Number 3 is the combination of any blood pressure medication with regular NSAID use. I'm highlighting this as its own entry because it is, in my clinical experience, the single most under-recognized driver of kidney damage in seniors with hypertension. And it is shockingly common. Here is the reality. Approximately 40% of adults over 60 who are on blood pressure medication are also regularly taking over-the-counter NSAIDs for pain, ibuprofen, naproxen. These are medications people pick up at the grocery store without a second thought. They're available without a prescription. They've been around forever. How dangerous could they be? Here's the mechanism. NSAIDs work by blocking a class of chemicals called prostaglandins. Prostaglandins are involved in pain and inflammation, yes, but they also play a critical role in regulating blood flow to the kidneys. When prostaglandins are blocked, blood flow to the kidneys constricts. In a young, healthy person, the kidneys compensate for this easily. In a senior whose kidneys are already operating at reduced capacity, whose blood pressure medication is already altering the renin-angiotensin system, this additional blood flow reduction can trigger acute kidney injury within days. A landmark study published in the New England Journal of Medicine found that seniors over 65 combining antihypertensives with regular NSAID use had a 500% higher risk of acute kidney injury compared to seniors on blood pressure medication alone. 500%. That is not a small number. That is not a statistical footnote. That is a crisis hiding in plain sight. And yet, how many seniors receive this warning? How many pharmacists flag this interaction at the counter? In my experience, not enough. Not nearly enough. Here's the pro tip for number 3. If you are on any blood pressure medication and you reach for ibuprofen or naproxen for pain, stop. Talk to your doctor about alternatives. Acetaminophen, also known as Tylenol, used at appropriate doses, does not carry this same kidney risk. Topical anti-inflammatory creams can address localized joint pain without systemic kidney exposure. Physical therapy, heat, gentle movement. There are options, but you must first understand that the combination you may be using right now is genuinely dangerous. Now, I want to share another story because this one is very close to my heart. I remember James, a 78-year-old retired postal worker from Chicago. He had been on a combination of lisinopril and amlodipine for his blood pressure for 4 years. He had moderate osteoarthritis in both knees. He took ibuprofen almost every day, 3 or 4 tablets, sometimes more on bad days. It was the only thing that let him keep moving, keep walking, keep feeling like himself. His son brought him to my clinic after noticing that James had become increasingly fatigued and was urinating less than usual. James had assumed the fatigue was the arthritis. He had attributed the change in urination to simply aging. He had not connected either symptom to anything his medications might be doing. His eGFR came back at 38. That is stage 3 to 4 chronic kidney disease. 2 years prior, it had been 62. We had a very honest, very difficult conversation that afternoon. James told me, "Nobody ever told me ibuprofen and my blood pressure pills were a problem. I've been taking them together for years." We worked on a pain management strategy that eliminated the daily ibuprofen. We adjusted his blood pressure regimen. We increased his hydration protocol significantly. Over the following 6 months, his eGFR stabilized at 41 and held steady. The decline had stopped. Not reversed completely, but stopped. He told me at his last visit, "Doctor, I feel clearer. I feel more like myself. I wish I had known this 5 years ago." So do I, James. So do I. This is preventable. This is reversible, at least partially, and you don't have to accept it as a sentence. Moving to number 2. Number 2 is the category of older generation diuretics, specifically loop diuretics, like furosemide and high-dose combinations of multiple diuretics prescribed simultaneously. While furosemide is most commonly associated with heart failure rather than straightforward hypertension, it does appear in the treatment plans of a significant number of seniors with complex cardiovascular profiles. And in the context of aging kidneys, It represents a serious concern. Furosemide is one of the most potent kidney-stressing medications in common use among the elderly. Its mechanism forces massive fluid and electrolyte excretion at a rate that younger kidneys can compensate for reasonably well. Aging kidneys cannot. The electrolyte disruption it causes, particularly affecting sodium, potassium, magnesium, and calcium simultaneously, creates a profound chemical instability inside kidney cells that is deeply damaging over time. Research published in the Journal of Applied Physiology found that elderly patients on long-term high-dose loop diuretic therapy showed accelerated loss of nephron function, meaning the actual functional units of the kidney, at rates nearly double those of age-matched controls not on the medication. And because the kidneys do not regenerate nephrons, once those units are gone, that capacity is gone permanently. Additionally, the aggressive fluid loss caused by loop diuretics in seniors who are not carefully monitoring their intake can lead to episodes of acute pre-renal dehydration, where the kidneys receive inadequate blood flow simply because there isn't enough fluid volume in the body. Each of these episodes, even mild ones, causes incremental kidney damage, and they are often attributed to weather, to feeling under the weather, to just a bad day, not to the medication. Here's the pro tip for number 2. If you are on furosemide or any loop diuretic, ensure your doctor is monitoring not just your potassium, but your magnesium and sodium levels as well. Magnesium depletion is particularly underappreciated in this context and directly impacts kidney cell integrity. Magnesium-rich foods, such as pumpkin seeds, dark leafy greens, and almonds, can provide meaningful dietary support, but discuss all supplementation with your physician to avoid interactions. Now I want to tell you about the most important engagement question of this video. If you believe that knowing your medication's effects on your kidneys could change how you manage your health, type yes in the comments right now. If you're skeptical that your specific medications could be involved, type 0. Your response shows others who are watching that they're not alone in asking these questions. And now, number 1. The most concerning situation for kidney health in seniors managing blood pressure is not a single medication. It is an unmonitored combination of multiple antihypertensives alongside inadequate kidney function testing. And the specific driver at the center of that combination is the unrecognized early kidney decline that changes everything about how medications behave in the body. Here's the critical insight. Kidney function affects how every single blood pressure medication is processed, distributed, and eliminated from your body. When your kidneys are functioning at 80% of normal, a standard dose of your blood pressure medication behaves roughly as expected. When your kidneys decline to 55 or 50% function, which happens gradually and silently, that same dose begins to accumulate differently in your bloodstream. Concentrations rise higher than intended. Effects last longer than expected. Interactions between multiple medications intensify. A study published in the Journal of the American Medical Association found that among seniors over 65 on 2 or more antihypertensive medications, nearly 38% had undiagnosed kidney function decline that was significantly affecting how their medications were metabolized. 38%. And the vast majority of those patients had not had their kidney function tested within the previous 18 months. This is the most dangerous scenario, not because any single medication is uniquely destructive, but because a combination of medications designed for kidneys that were functioning at the level they were at when the prescriptions were written is now operating inside a body where the kidneys are quietly performing at a lower level. And nobody has recalculated the dosages. Nobody has reevaluated the combinations. The prescriptions simply continue year after year, refill after refill. Here's the pro tip for number 1, and it may be the most important thing I say in this entire video. Ask your doctor for a comprehensive kidney function panel, specifically creatinine, BUN, and eGFR at every single annual exam. Not every 2 years, every year, if your eGFR has declined by 10 or more points since your last measurement. Ask your doctor to specifically review every medication you are taking and whether the dose or choice remains appropriate for your current kidney function level. That conversation, that one conversation, is the single most powerful thing you can do for your kidneys right now. I want to share one more story, and this one represents hope. I remember Dorothy, a 71-year-old retired nurse from Boston. You would think, as a nurse, she would know to watch these things. But she told me herself, When you're the patient, you hand yourself over to the system and you trust it. She had been on 3 different blood pressure medications for 8 years. Her pressure was controlled. Her cardiologist, her primary care physician, everyone was satisfied. She came to see me because her sister had been diagnosed with kidney disease, and she wanted to know her own risk. Her eGFR was 49. Her creatinine was elevated. She was already in moderate kidney disease, and she had never been told. But Dorothy was a nurse. She was ready to act. We worked systematically. We reviewed every medication. We identified that one of her 3 antihypertensives was redundant, given the kidney impact it was creating. We modified her hydration and dietary protocols. We eliminated a daily NSAID she had been using for lower back pain. 12 months later, her eGFR had climbed to 57. That is a significant improvement. That is her kidneys partially recovering after years of compounded stress was finally removed. She called my office on the day she got those results. She said, "Dr. Whitfield, I feel like I got a second chance, and I didn't even know I needed one." You don't need to wait for a sister's diagnosis to ask these questions. You can ask them today. Now, let me tell you exactly how to implement what you've learned. Start this week by locating your last lab results. Find the value labeled eGFR or estimated glomerular filtration rate. If it is above 60, your kidneys are currently functioning in a generally healthy range. If it is between 45 and 60, you are in a stage where vigilance is critical. If it is below 45, you need a conversation with your doctor as soon as possible. Schedule a kidney function panel if you haven't had one in the past year. This is a simple blood draw. It takes minutes. It tells you everything you need to know about where your kidneys stand right now. Make a complete list of every medication, supplement, and over-the-counter product you take regularly, and bring that list to your next appointment. Ask your doctor this specific question. Given my current kidney function, are all of these medications and doses still appropriate? If you take any NSAID regularly, including ibuprofen or naproxen, discuss alternatives with your doctor this week. Acetaminophen at appropriate doses is a safer choice for most seniors on blood pressure medication. Topical anti-inflammatory creams, physical therapy, and heat therapy are additional tools worth exploring. Prioritize hydration, especially if you are on any diuretic medication. Seniors on thiazide diuretics should be drinking at minimum 6 to 8 glasses of water daily, more in warmer months or during physical activity. Dehydration and blood pressure medication are a dangerous combination for kidneys. Include kidney-supporting foods in your daily routine. Dark leafy greens like spinach and kale support kidney cell health. Berries, particularly blueberries and cranberries, contain antioxidants that protect kidney tissue from oxidative stress. Olive oil provides anti-inflammatory compounds that reduce the kind of chronic low-grade inflammation that accelerates kidney decline. And above all, reduce sodium intake, which directly reduces the strain on your kidney's filtration system. Do not make these critical errors. First, do not stop any blood pressure medication on your own without medical guidance. The risks of uncontrolled hypertension are real and serious, and nothing I've said today is a recommendation to discontinue your medication independently. Second, do not assume that because you feel fine, your kidneys are fine. Kidney disease is called the silent killer for a reason. It does not announce itself until it is advanced. Third, do not wait until your next annual appointment to ask these questions if you are already on multiple blood pressure medications. Call the office, send a message through the patient portal, ask for a lab order. Your kidneys cannot wait for the calendar. Within 1 week of increasing your hydration and beginning a kidney-aware dietary protocol, many of my patients report feeling less fatigue, better morning energy, and improved clarity. Within 2 to 4 weeks, early-stage inflammation markers begin to shift. Within 3 months of removing nephrotoxic combinations, kidney filtration markers often begin to stabilize or improve. Within 6 months of consistent protocol, some patients see measurable recovery in their eGFR numbers, as Dorothy did. Your body wants to heal. It just needs the right conditions and the right information. So let me summarize what we've covered today. We walked through 7 key concerns in blood pressure management and kidney health for adults over 60. We discussed the kidney stress caused by thiazide diuretics and the critical importance of potassium monitoring. We looked at how calcium channel blockers can trigger edema and secondary kidney strain. We examined the complex and often underappreciated risks of ACE inhibitors and ARBs in patients with undiagnosed vascular narrowing. We highlighted the extraordinarily dangerous and shockingly common combination of blood pressure medication with regular NSAID use. We reviewed the potent kidney toxicity of loop diuretics and the electrolyte disruption they cause. And we identified the most dangerous situation of all: unmonitored kidney function decline that goes undetected while medication combinations continue unchanged year after year. Each of these situations is manageable. Each one has a strategy, but only if you know about it. My message today is not panic. My message is not to throw away your blood pressure pills. My message is empowerment. You are not powerless in this situation. You are not simply at the mercy of what happens to your body after 60. You have agency. You have questions you can ask. You have tests you can request. You have conversations you can start. Here is my challenge to you. This week, before you do anything else health-related, find your most recent lab results and check your eGFR. If you don't have recent lab results, call your doctor's office and ask for a kidney function panel. Just that one action. That is your homework. That is your starting point. Because the difference between Margaret, who caught her kidney decline at stage 3 and was able to stabilize it, and the patient who discovers stage 4 kidney disease when it's too late to meaningfully intervene, is often just one blood test taken 1 year earlier. Age does not take away your body's ability to recover. It simply reminds you to care for it the right way. If this video helped you today, please smash that like button. Subscribe to this channel so you never miss the practical, clear health information I share every week specifically for adults over 60. And share this video with someone you love who is on blood pressure medication. You might just give them the conversation that changes everything. Now I want to hear from you. Have you ever had a doctor discuss your kidneys specifically in the context of your blood pressure medication? Have you ever checked your eGFR? Share your experience in the comments below. I read every single one. And your story might be exactly what someone else needs to hear today, because remember, you're not broken. The system that was supposed to inform you may have let you down, but that changes right now. Take care of yourself.